Well, thank you very much to the Cardiothoracic Society of India for giving me this opportunity. It's truly a privilege and honor to be here talking about this topic. I don't have any disclosure, no financial association. Over the next 12 minutes, what I'm going to be talking is a use of AI, whether it's just a buzzword or can we use it as a planned utility, and then a framework of healthcare AI in low to middle income countries, and then some of our experiences and the lessons learned from it. So I say, can AI be planned well? Absolutely, it can be. One just has to avoid the buzz around this whole word. And when planning our AI, one has to be plan it in a patient-centric value addition way. And also have to understand that it's a complementary tool, not a replacement of what the physicians or surgeons do. That's one of the fears. And then know your problem and your context. So what is our context? I think it's important to understand that so child born in the US on the left-hand side, prenatally diagnosed, comes to the system pretty early, gets operated, goes back to a good family with good resources versus our patient who comes in on the left-hand side, who's infected, malnourished, and comes pretty late in their disease, and then has to go into a family or a setting that has significant amount of access issues. So not only getting to a healthcare facility for management, but also once they go back to treatment, the follow-up and stuff also depends hugely on this. And in fact, when they get sick, even at the time of the first diagnosis or follow-up later on after surgery follow-ups, the first contact that they have is actually a healthcare facility or healthcare workers who are not as skilled. So keeping that in mind and also understanding that a lack of specific skilled professionals in our part of the world and the amount of brain drain that specifically hits maybe not that much the physicians and the surgeons who we still are able to attract, but actually specifically hits our allied health and nurses, and that's where we really kind of hurt at times. And so one can understand that if a case not only in the West, but when the case is presenting early, gets diagnosed at the right time, they get management and come back after management into a very highly functional, comprehensive system with multi-team approach versus in our setup where we may not have the most skilled person taking care of these complex patients who already have come with quite a bit of complexity and comorbidity. And then the cost implications of all that we do. And I think that cannot be ignored. This is some amazing work from K.K. Kumar and his group from Kerala that has shown that how families kind of get into a poverty trap because of what we do. So it basically then gives us this whole healthcare paradigm in our part of the world where the resources are significantly less, and resources in every manner, human and other resources in technology, resources in our ability to automate stuff and actually really get away with some of the algorithmic work, and then the whole complexity of disease with the number of patients. And one can always look at this as a major challenge, but at the same time, one can look at it as an opportunity to really innovate and implement and scale. And the changing paradigm in how the world is changing around digital networks, communication, the way people receive and get communication. One can see this very clearly how significantly the bar of of smartphones and internet use has gone up significantly compared to other measures like improved water, sanitation, and all of those. And so one keeping that in context also is how one can innovate. So there's a document which is amazing, which I would recommend everybody who's kind of about to venture on this path of AI in low to middle income resources. And what this document basically says and gives a very good framework. And the key principles behind this is to complement best practices for global health, strengthen local health systems, and then it should be owned and driven by the needs of low middle income countries. So if we understand our context, if we understand what our problems is, and we create solutions around it, and that's what this document is kind of proposing. And they kind of break down, 4 different domains. And if AI or any kind of technology is brought in, will make the most amount of difference. And what we did, and the kind of projects that I'll show over time, I'll show you some of these domains that we kind of hit, and we kind of use this document as our kind of starting framework towards getting into this whole journey. And the whole idea behind that was, how do we really use the concept of task sharing? So augmenting the skill sets of people who are not as highly skilled, but who are at the front line, and kind of really doing that task sharing in healthcare delivery. And then also doing it from the lens of the care continuum. One cannot bring in a tool in just one part of the care continuum of the patient, but actually have to think about improving care delivery at every part of the care continuum, and that is what will improve the outcome eventually. And then understanding, and this is again a slide from KK Kumar, and understanding where the problem lies, and how can one target those problems using some of technology and some of the AI and stuff. And then whichever collaborator that you work with has to understand the context in which this work is being done. And so you can look at our collaborator, Dr. Bart Benin, who is the engineer from Barcelona and has spent 30 years of his life working on cardiovascular physiology, and Dr. Vigyani Chaudhary, who works out of Lancaster, Pennsylvania, and works on the Amish population, and kind of understand the context, because the Amish also shares similar kind of context as us. And they actually came and have spent time in our communities to understand how to develop the solutions around the problems that we are facing. So this is the first project I'm going to talk about, and this is the machine learning project from the fetal waveform. And the whole idea behind this was funded by the Bill and Melinda Gates Foundation, was to create a machine learning model using fetal Dopplers acquired around 28 and then 32 to 34 weeks to predict perinatal mortality, and also to predict small for gestational age. This was done in a small suburban area, which was in Karachi, and this is an area which is close to the water. The majority of the people there, their profession is fishing, and this is kind of that setup that this work was done in. And you can see it kind of mimics some of the setups that will resonate with people listening to this talk. So we got these patients from the community. We acquired Dopplers on them from multiple areas of the heart and vessels, and then this is one of our sonographers acquiring that from the community, and then using conventional fetal biometry, conventional Dopplers that people use, the PIs and the RIs. We also then segmented these Doppler signals manually, and I'm going to stress on the word manual, because that's one of the lessons learned when we were trying to scale this work, as in how difficult it becomes, and why the need of automation. So the study outcomes, again, as I mentioned, stillbirth and small for gestational age. This is the demographics: 25 stillbirths, 19 neonatal mortalities. And we use multi-kernel learning technique, which basically is a way of creating a low dimensional space using similarity of features. And this is an unsupervised machine learning technique. And then we sprinkled that space with our patient outcomes and created a supervised, so a mixed method machine learning. And then we also then went and looked at why these patients were clustered together and what were the similarities between their Doppler to try to create a physiological sense of the black box. And all of this technique led to pretty good sensitivity specificities and area under the curves of predicting mortality in small for gestational age. And not only that, when we applied this model on a bunch of fetuses from Barcelona who has not seen this model, the model was able to predict the high-risk fetuses among those, and which were 21 tetralogy of flow patients. We then also broke the model down in creating 4 low-tech Dopplers so that it can be scalable. And this is our validation grant now, in which we are creating the pathway in assessing the initially collected data, and then also looking at the cardiovascular changes in patients who were born, and then eventually to do a validation on 6,000 patients. And that's what made us automate a lot of our work, because it kind of created these challenges. How do you train, and how do you do quality improvement on images? How do you create an image pipeline? How do you automate and segmentation? How do you create a platform to integrate data, run analytics, and create actionable prediction out of it? And then also the importance of ground truther and physicians. And so we have created this platform. We have started automating. We have actually started acquiring images directly from the machine, from the community, and have been able to auto segment now everything, actually building in physiological changes in the Doppler also. And that physiological changes was brought in by the ground truther, which is physicians giving feedback to the machine learning model of what the mistakes were being done. This is our second project, which is a pulse oximeter project. And basically in this, we were using machine learning to predict using WHO signs and symptoms, pulse oximeter, to predict at-risk neonates, which is critical congenital heart disease, sepsis, hospitalization, and death in the first month of life. And what we learned from this was there's no one-stop shop model. Actually, what one has to do is to do machine learning in a sequential way. So using some of the tools like WHO signs and symptoms, pulse oximeter initially, to then pick the high-risk fetuses and then apply the machine learning model, and that gives you the best sensitivity and specificity. And now we are also now dwelling into doing machine learning on the waveforms of these Doppler signals. So the lesson learned from this project was that there is no one-stop shop solution in machine learning. Mimics the behavior of the age-old time-tested diagnostic flow. And when we physicians diagnose, we diagnose it in a sequential manner. We take a history, we take a physical exam, we come up with a likelihood ratio, and then we go into testing. And that's what we are proposing, that rather doing a one-stop shop, one crystal ball machine learning, one should do it in a sequential manner and do it on those fetuses that are selected to be done on machine learning. This is our third project, which is applied in the cardiac ICU. It acquires all the data, high velocity, high volume data from the bedside into the cardiac ICU and gives a prediction of how the baby is doing. And this is, it basically, and I'll run this video, it basically picks up the data from the bedside and gives you a prediction in a line up on the screen. And as the line starts getting red, and you'll see that red line kind of coming, it shows that the patient is getting into a low cardiac output or low tissue oxygen delivery. And as you act on it, it starts becoming green and makes you react on the patient. And so we were able to show some good prediction of tissue oxygen delivery in our population. We actually published a great paper out of it, but our mortality did not decrease. And the learning from this project was that we did it with the focus of implementing this tool was completely different. And we did not think about creating a framework of implementation around it. And that's why we didn't see any benefit of such a tool. Our last work that we are now trying to venture into is this work being done by Dr. Juan Sanchez, who is in Barcelona. And it is the work around understanding how data is processed. So currently, the way we acquire data in our clinical workflow is, again, this is all unprocessed data. If you take a history, do a physical exam, once you start putting it into a system, even if you write your physical exam down, that's already processed data. And one would lose a lot of information if one is doing data mining on processed data. So what Dr. Juan Sanchez has done and has proven is that one can use a data twinning technique in which the unprocessed data is not only is put it as in a processed form into one platform, and the unprocessed form is actually put into another data lake where you can do a lot of data mining. And he's actually done some of this work in his cardiac ICU, has created a predictive model using the traffic light approach, and has shown significant improvement in his outcomes in his cardiac ICU. So the lesson learned from him was that when you plan your data pipeline, you have to plan your data pipeline properly, try not to lose data, understand what is raw data and what is processed data, and then negotiate with your device companies smartly so that you can put things into your procurement contract of acquiring raw data. And also to create teams. Healthcare is no longer a physician or surgeon-centric approach. It has to create teams in which you have IT specialists, data scientists, and other people who will help you deliver better care. So we have done a similar kind of an approach in creating a team. And my final lesson from all of the work that we've done is that our patient populations are unique, and this is our strength. What we do in our part of the world matters to 90% of the world population. And this is our chance to innovate and to really contribute to global science in implementation and scalability science.